So, this is part two of vital signs, beginning with respirations. Part one includes the last thing we did was pulse. Since respirations are automatic and they're also voluntary, we need to remember to not mention to the patient that we are counting their respirations because sudden awareness of that will alter the normal pattern. The patient will start to breathe for you so that you can count it. We don't want that. We want a natural, unknowing respiratory rate. So we will do that while we're counting the radial pulse. So after you're done counting the radial pulse for 30 minutes, then you will shift your gaze to the patient's rise and fall of their chest or their abdomen if they're a belly breather, and you will count the respirations for 30 seconds. Then you will take your pulse and you multiply that by 2, and then you take your respiratory rate and you multiply that by 2. Sometimes it's hard to count the respiratory rate for 30 seconds, so you may opt to count the respiratory rate for a full minute. Always, if there's abnormalities, you will also always count for a full minute to get a more accurate reading. For a healthy adult, we want to remember that mainly average normal breaths are between 12 and 20 breaths per minute, and they can range from 16 to 25. But we want to remember 12 to 20 is our magic numbers for respiratory rate. Now, blood pressure is defined as the force of blood pushing against the side of its container, which is the vessel wall. So, blood pushing against the side of the vessel wall is the blood pressure. The strength of that push changes with events in the cardiac cycle. So, we had the first event, which is systolic pressure. Systolic pressure is the top number in the blood pressure reading. It's the maximum pressure felt on arteries during the left ventricular contraction or systole. And then there is the diastolic pressure, which is the elastic recoil or what we call the resting phase of the pressure of the blood that exerts constantly between each contraction. So, how much blood is in that heart vessel that is exerting pressure on relaxation? Now, the pulse pressure is defined as the difference between the systolic and the diastolic pressure. Now, that also reflects the stroke volume. The stroke volume is the volume of blood pumped out of the left ventricle of the heart during each systolic cardiac contraction. So, if we have higher stroke volume, we're going to have a higher systolic blood pressure. Now, another part of the blood pressure is the mean arterial pressure, the MAP. We really like to look at the MAP in ICU situations to check on perfusion. It is the pressure forcing the blood into the tissues, averaged over the cardiac cycle. We like our mean arterial pressure to be at least 60 or greater to maintain adequate tissue perfusion of oxygenation and nutrients through that pressure. There are different variables that affect the blood pressure readings. Age is one of them. Generally, infants and children have lower blood pressures than adults, and as we get older, blood pressure goes up. Gender also has an effect on blood pressure. Females tend to have a lower blood pressure than males, except after menopause when females' blood pressure will be higher. Race makes a difference in blood pressure readings. We have genetics and environment to consider. So, like African Americans, are more predispositioned for hypertension due to the genetic component. Social determinants are effects of the environment and social factors that lead to an increased risk of hypertension. That's your lifestyle things that increase your risk. Other things that affect blood pressure are weight. Obesity increases the blood pressure compared to a normal weight, recorded measurements of the same age. Exercise, of course, will increase that cardiac output and stroke volume and increases our blood pressure. Emotions and a stress response will increase that vasoconstriction and hence increase the blood pressure. And that goes along with stress. So, stress response increases the tension in the body with that vasoconstriction and the sympathetic nervous system all working together. Now, take a look at this diagram of a blood pressure. The systolic pressure, right here, oh, systolic pressure is at the maximum pressure felt on the artery during the left ventricular contraction. Okay, then the diastolic pressure down here, diastolic pressure is the recoil or the resting part of the heart contraction. And then the pulse pressure is the difference between the systolic and the diastolic pressure and reflects the stroke volume. Next is the mean arterial pressure. Look how it's kind of right here in the middle, but more on the lower third. It is the pressure forcing blood into the tissues averaged over the cardiac cycle. It's really calculated in a formula of a diastolic pressure times 2 plus the systolic pressure divided by 3, and that will equal the MAP. It's also calculated by the diastolic pressure plus a third of the pulse pressure, which is that difference, and that will also give you your MAP reading. Remember, we want the MAP to be at least 60 for adequate perfusion. So this page really explains how blood pressure is affected by different things within the body. We have cardiac output. An increase in cardiac output leads to an increase in blood pressure, whereas a decrease in that cardiac output leads to a decrease in blood pressure. So when we have that increase in cardiac output, for example, with heavy exercise in order to meet the body's demand for increased metabolism, we have high blood pressure. We can have lower blood pressure with lower cardiac output if our heart valve is not working correctly and we have a weak pump and it's not getting the blood out. So we have a poor cardiac output that's going to lead to a poor lower blood pressure. We have vascular resistance. Increased resistance, like with vasoconstriction, can lead to an increase in blood pressure. And a vasodilation, when you have enlargement of the vessels, can lead to a decrease in blood pressure. The volume of circulating blood, so fluid retention, fluid buildup, how much fluid is in that patient's body leads to an increase in blood pressure. Whereas if you lose a lot of blood and you hemorrhage or you lose a lot of fluid through too much diuresis, that can lead to a decrease in blood pressure. How thick your blood is, the viscosity associated with increased blood pressure, and how elastic or rigid your walls of the arteries are. That's usually caused from atherosclerosis or arteriosclerosis and buildup of cholesterol and calcium deposits in the arterial walls. It makes it impossible for their arteries to do their job correctly. And here is another diagram of what we just talked about of how these 5 things affect blood pressure. When taking a blood pressure, the patient can be sitting or lying, but you would want to document what their position they're in when you take the blood pressure because that can make a difference. We want their arm to be bare. Although we do place the cuff over patient's clothing sometimes, you do want to have the arm exposed, the bare arm. At heart level, you want to palpate the brachial artery, and then with the cuff deflated, you'll center it about 2.5 centimeters above the brachial artery and wrap it evenly. So you're going to find the artery first. This is called the 2-step blood pressure method, which is what we will learn. Palpate that brachial artery and then inflate the cuff. Once you get the cuff positioned above it, inflate the cuff until the artery pulsation is no longer felt, and then about 20 to 30 more millimeters of mercury above that. This will make sure that you avoid missing the auscultatory gap when the Korotkoff sounds disappear during auscultation. So then you will deflate the cuff quickly and then wait 15 to 30 seconds before reinflating the cuff so that the blood trapped in the veins can go back to normal. Place the bell of the stethoscope over the brachial artery, but making a light but airtight seal. You can use a diaphragm end piece, but it's not as good as the bell is. Rapidly inflate the cuff to maximal inflation of the level you determine that it should go up to, and then deflate the cuff slowly and evenly, about 2 millimeters of mercury per heartbeat. Then note the points at which you first hear the sounds, the muffling, and then the final disappearance of the sound. You're going to document the first and the final. So up here you can see someone palpating for the brachial artery. The cuff size looks good. It's not too big, not too small. There's a standard adult arm cuff that fits most people, and then there's going to be a large adult cuff. This is the large adult size, and then they do make a thigh cuff specifically. And this is the procedure for taking a thigh blood pressure if it's been ordered for your patient. The carotid cough sounds are the final sounds that we hear towards the end of the blood pressure reading. We want to hear the first sound, that'd be your systolic blood pressure, and then that final sound, the last sound we hear, will be the diastolic pressure. Okay. Although that we like systolic is the most important one, we also still record the diastolic blood pressures. Here's a visual example of how to take blood pressure with listening to the sounds. So in the beginning, you're not going to hear anything. And then you're going to slowly listen, and then you'll start to hear it come in. That's your first sound, the very first one. So we heard it here, so it would be 120. And then you're hearing, it becomes muffled, and then nothing. So right here is the last time we heard it, so that would be your last sound here on the dial. It says 80. So you want to make sure you're listening for the first one and the very last one. Not when it starts to muffle, but when it stops. It's important that you become really good at knowing exactly how to take blood pressure the manual way, because errors in taking a blood pressure can lead to errors in measurement. So what leads to errors in blood pressure measurement? When you are taking a blood pressure after someone's been very active, they've just got done exercising, maybe they were really exerted walking from the car to the clinic, or if they're really in an emotional, unstable state, those are going to lead to abnormally high readings that is not a rest in blood pressure. That would be responsive to the situation of the patient. A cuff that's too little, too narrow, or applied too loose, or reinflating during the procedure. Those can lead to high readings. Low readings are from decreased inflation, so not inflating it too much. Too large of a cuff. If you get a big cuff, you're going to have a false low reading. Position of the arm or leg is not in proper position, so it should be arm level. Using that improper cuff size and deflating the cuff too quickly. So another set of vital signs is called the orthostatic vital sign. This is taking measurements of the pulse and blood pressure in certain situations like volume depletion, dehydration, or fluid volume depletion. The person has been known to have hypertension or is taking some sort of antihypertensive medications, high blood pressure medicines. The patient reports fainting or syncope, or position is changed from supine to standing. Normally, slight decrease in the systolic pressure may occur. When we take orthostatic vital signs, we'll have the person rest flat on their back, so supine, for a couple minutes, take a baseline reading of their pulse and blood pressure, then have the person sit and then sitting and then take it again, and then standing and take it again. For the person who's too weak or dizzy to stand, assess the blood pressure supine and sitting with the legs dangling. will record the blood pressure, and then we will document what position, arm use, cuff size, and any pulse rhythms and whether the pulse is regular. A thigh pressure is not commonly used. We only use this as a last resort. And then we want to make sure our physician knows that we're taking the blood pressure in the thigh. It is very, very rarely used, and we should never use this method as an excuse to not use arms. Um, we with when the blood pressure on the arm is really excessively high, we can compare it with the thigh pressure to check for certain congenital heart disorders like coarctation of the aorta. So obviously on a regular patient, and we don't suspect some sort of significant cardiac thing to be going on, we're not going to use a thigh pressure. um, we would say particularly in adolescents, young adults, because they could be more at risk of just now figuring out that they have a heart issue. um, Normally thigh pressure can be higher in the arm. We like the patient to be on their belly, so prone position. We use an extra large cuff, and we use the popliteal artery. Now, we don't usually check blood pressure in children younger than 3. It's just not a pleasant experience for them. They're not usually going to give us a whole lot of information about them with a blood pressure, because you don't see a whole lot of 3-year-olds with hypertension or cardiovascular disease. So it's not really something we're not screening 3-year-olds for hypertension. We will avoid the rectal route if we can and use other routes of temperature taking for children, and axillary is the best way unless they can follow your directions for an oral temperature. With babies, we're going to do a reverse order of vital signs. So we do respirations first. So basically, we'll do the least amount of touching first, respirations, pulse, and then temperature last, because we may have to hold them down for a temperature, especially if we're going to use the axillary. We can let the preschooler play with our equipment to get used to it before we use them. Same for school age and adolescents. We can treat them like adults when taking their vital signs. Okay, let's talk about infants and children. With a pulse rate, we're going to listen with our stethoscope and get an apical pulse for infants and toddlers. With children older than 2, we can use a radial site, but it may still be easier to use the apical pulse with the stethoscope. We're going to count for a 1 full minute, and then it can fluctuate because the heart rate can fluctuate with infants and children. They're very sensitive to exercise and emotion and illnesses, so their heart rate will fluctuate a little bit more. Respirations, we can watch the infant's abdomen because they're belly breathers, and then we can watch their respiratory rate. Sleeping is really good because that's just easier when they're not moving around or crying. It's just easier to count. We'll do a full minute for infants and children. So we like to use electronic blood pressure cuffs for children younger than 3 because it's just quicker and it gives us an accurate reading, and because of the movement and how small children are. Or you can use a Doppler to help get those readings. With aging adults, we want to remember that their temperature can be lower and they're at more risk for hypothermia. A normal pulse rate in the older generation, they can have a lower pulse rate and it can be slightly irregular. The radial artery can feel stiff and rigid and tortuous in an older person, although it's not necessarily means they have vascular disease. They have increased rigid arterial walls, and they have a need a faster upstroke of blood, so their pulse is easier to palpate sometimes. Since arteries tend to harden with age, like with calcium deposits and high lipids. It can cause a stiffer aorta, which causes an increase in systolic pressure and a widened pulse pressure, which increases blood pressure all around. So as that increases, it's difficult to distinguish between normal aging and from abnormal hypertension. We can use a pulse oximeter to assess the SpO2 or the oxygen saturation of the patient's blood. We use a sensor. We can use a finger or an earlobe. It has a light, a detector on it. It picks up the HbO2 and non-oxygenated hemoglobin. It compares that ratio of light and gives us a percentage of oxygen saturation. In a healthy person, we like to see it above 95%, but a really healthy person should be around 97 to 99% or 100% on room air. We do use the electronic vital signs monitors at Dynamaps in clinical settings. It is fast, it has automated settings, it can give you a blood pressure, a map, and a pulse. It can also do temperature and pulse oximetry. So it's really convenient, but we need to learn how to use that method as well. With hypotension, that's low blood pressure, that is less than 90/60 is considered hypotension. Children under expected value based on age. So if they're lower than what they are on the age chart compared to what their blood pressure should be. We also see hypotension in acute MIs, shock, hemorrhage, vasodilation, and Addison's disease. Now, essential or primary hypertension has no known cause and accounts for 95% of almost all hypertension cases in adults. We use the AHA blood pressure guidelines and we look at the stages of hypertension that they are based on what their blood pressure reading is. Things that impact organs with hypertension, as smoking causes hypertension, high lipids in the blood cause hypertension, diabetes can have it play a role in creating hypertension, especially if they're above age 60, if they're a man or a postmenopausal woman, a family history of cardiac disease, women under 65 years age under 65, and then men over 55 who have a family history are at risk for hypertension. We need to teach health prevention and management of hypertension. So we would promote weight loss activities, limit alcohol use, increase exercise. We can say take a walk for 30 minutes 3 times a week, reduce sodium intake, maintain adequate sources of dietary potassium, calcium, magnesium. That would be eat more vegetables, smoking cessation, try to decrease the amount that you smoke, and reduce the intake of saturated fats and cholesterol. So, a low fat diet, high in vegetables, and low carbs for weight loss if they are overweight. So we do need some carbs, but they can decrease the amount of carbs that they ingest.